It's a very difficult movie to see, a lot of suffering, and I'm just, and a lot of unprofessional physician behavior. So I just want to be maybe as much as possible cautious about not making this about bashing or beating up on a particular group of physicians, because I think we're here really mostly to link this to the Overdiagnosis Conference. So just with that as a starter, Brooke, is it okay if I start with you? I mean, you gave an interview on Eye Opener this morning, and I thought, given your experience, it might be good for you to share your story with the people who are with us today.
Sure. Am I on? Can't quite tell. Am I? Excellent. Hi, everyone. My name is Brooke Siem. I was not in the documentary, obviously, but Lynn and I have connected because I have a story that is very much in the vein of everything she's shown in this documentary. I would encourage people, there's a longer version out there that has a bit more about withdrawal side effects and vets, and so I would encourage people to watch that as well, because it's an important part too. But for me, my story is that when I was 15, my father suddenly passed away, and I, within 6 months to a year, was on 6 different medications. They started off for depression disorders and also anxiety disorders. And what then happened is I started having a bunch of physical symptoms, stomach aches, and my hair was falling out. And then I got passed along to gastroenterologists and endocrinologists. So by the end of this year, by the time his year anniversary had happened, I was on 6 different drugs. And I stayed on those same drugs for the next 15 years. And like many of the people in the documentary, despite living in 3 different cities and colleges, and I was in New York, no one ever questioned the amount of drugs I was on, whether or not they were working, or, gave me any prompt to be my own advocate and do my own research. I was 15 when I was put on these drugs, so it wasn't like I had any awareness of this world. And when I turned 30, so I had been medicated my entire adult life, I was starting to have suicidal thoughts, and I just kind of had a light bulb moment of realizing that if I was on antidepressants, I probably shouldn't be feeling that way. And just kind of clicked, I guess. It took a while. I had been going steadily downhill, but that combined with an opportunity to travel around the world for a year, and at that point I was having memory issues, so I couldn't remember. I was missing conversations with my business partner, and then she'd yell at me, and it wasn't great. But I realized if I was going to travel for a year, then I probably would like to remember it. And so I saw a psychiatrist, and a new one, and she wasn't supportive of me getting off the drugs, but I was really determined to figure out a baseline. At that point, I wasn't sure if I needed to be on something different. I didn't really have an opinion on, antidepressants or psychiatry as a whole. I just knew that I needed to know what I was like as an unmedicated adult before making any choice about my life going forward. And so she, at that time, I was on 37.5 milligrams of Effexor, which is the lowest dose available on the market. And she said, okay, well, just stop. Can't prescribe you anything less. And that's when I was plunged into withdrawal, most similar to the gentleman in the Medicating Normal. So, for me, there was huge, violent thoughts about myself and towards others, and I had, my eyesight got better, my hearing got more acute, I stopped being able to wear clothes because my skin hurt, so all my senses just really kind of went on overdrive. I had huge bouts of rage and mood swings that would, could bring a grown man to their knees. And it just wouldn't relent. It lasted for almost a year before I started to stabilize. In that time, I started to do some kind of pretty unconventional counseling and therapy because I wasn't getting what I needed, and talk therapy, and kind of approaching things from a little bit of a blend of Eastern and Western kind of modalities seemed to help me process what I was going through. And also, my mom's here, and she was one of the most important parts in my healing process as well, because throughout the whole thing, she never saw me as a broken person, and that was just so, somebody had to be that lighthouse for me, and that was her. But all that to say, I, again, like the gentleman in the Medicating Normal, I got really mad, and I knew that these drugs were the cause of my symptoms, and so I refused to go back on them, and I just decided I was going to weather it one way or the other. And I was lucky that after about a year, I did start to stabilize and trust my own body. And now it's been 6 years since I've been on these drugs. I now speak, and I've written a book that's coming out in September. It's called May Cause Side Effects. It is going to be the first book on antidepressant withdrawal for the mainstream consumer market, and I feel a huge responsibility to have written that book and to have it out there. It's available already in Australia, the UK, Canada, and the US, and I get messages every day from people who are in the same state of despair that these people were, and I just can't wait for them to have it because I want them to know that it's possible to recover. And that's pretty much my only message in this world, is that it is possible to get better, because no one other than my mother told me that when I was going through it, and that is what kept me alive. So.
Lynn, can we turn things over to you and share some thoughts?
Thank you, Eddy, for inviting us to screen at this wonderful conference, and I applaud all of you guys and the work you're doing. I just think it's very hopeful for the future of medicine that this group of people is getting together and continues to. The film was never meant to be a doctor-bashing film, and I'm just addressing that because that's sort of what Eddy addressed first off. We felt really, we went through phases making the film of real anger, such anger that, believe me, we wanted to make it into a doctor-bashing film. But we realized, A, it's not true. The world is filled with many great doctors. It's also true that many people do not have the issues that you all are seeing in the film. Some people really do well on their drugs, and they're needed. It's just that this was a story that was not being told. At least 7 years ago, it was not being told. You could not Google anything about withdrawal. Even the most open-minded of the doctors, that we interviewed, they might have admitted that there were issues with benzodiazepines, but there was very little acknowledgement about antidepressant withdrawal. And Brooke is right. This book is incredible, and she writes really well about it. And so we made the film really to tell a different story. And it was, for me, I got into the film based on a loved one, a family member who was going through this. And not to go too much into her story, what I realized 10 years into her medication, she had gone from one drug to 10 meds in 10 years. She had what's known as a severe mental illness. I think it started not severe, but it turned out, and I didn't understand why in the DSM, the drugs she was taking they kept switching different drugs, and you would read that one drug was for one disorder and another, and if you really start to read the DSM, it does not make sense at all. And that confusion on my part and trying to help her clarify what she was going through really started the research on this, and it led me to the work of Robert Whitaker, who, I think he should get a Nobel Prize for what he's done in opening people's eyes. So that's how it all began. And then my filmmaking partner, Wendy, and I thought, okay, we've read this incredible book. This is amazing. Is this really true? I mean, I remember reading excerpts of Anatomy of an Epidemic to my husband, who was like, no, that is just, it can't be true. We have an FDA, just get off of it, Lynn. And I was like, but read he wouldn't read the book because he was too busy, but I would read excerpts. And slowly, as my filmmaking partner, Wendy, and I we started to go to the support groups that Shalimar visited. We started to advertise that we were interested in talking to people who were going through some of the adverse effects. It was hundreds, more than hundreds, 200 people whose stories were not exactly the same, but they had the same pattern. Went to the doctor, wasn't believed. It just wasn't the case that this could be causing this. Another drug was added. I started losing functionality. And so this story kept repeating itself, and it was not in the major media. It was not at all. The major media was all about the miracles of these drugs, and there was such a disconnect that we just felt, well, this deserves to be looked into, and we need to make a film. So anyway, that's
Thank you, Lynn.
That's the beginning.
And I don't know if I mentioned it, but the film is making quite the tour of PBS stations in the U.S. lately.
Yes, it's being broadcast as a special around the country on PBS. You can also stream it on PBS. Brooke is right. There is a 76-minute version that I like better, but Eddy and we just decided that for this conference, a shorter was better because you guys have been at a lot of lectures. But the 76-minute version really goes into veterans and what they're experiencing. And, it's much more veteran focused, and I like, and it also has a little bit more on each character. But
And akathisia as well is in that, which
Yeah.
is important.
yeah, akathisia is which
Isn't there like a scene with Angie where she can't stop shaking in the other one?
yeah.
This could be a good segue for
Yeah.
Dr. Wright to tell us maybe a bit about what akathisia is and his thoughts on the Medicating Normal movie.
So this is the third time I've seen the movie, and I still love it. And I thought maybe my memory was going because I thought I missed some of the spot, but now you told me that.
Yes.
I saw the longer version before, so yeah. And
The
the
longer
longer
version
version is very good. I'm a clinical pharmacologist, and I've practiced medicine for over 40 years. My specialty is prescription drugs, and I've studied these. For the last 25 years, I've had the benefit of being part of the Therapeutics Initiative, which is out of University of British Columbia. And because of that, we had a group of dedicated people who were able to carefully look at the evidence of that led for these drugs to get on the market. So I'm highly aware of what the evidence is, and it's not possible for anybody else to have the time, because it takes hundreds of hours to go through one drug and really find out. But when you see the evidence, I was, and I'm sure you would be, you'd be shocked at the fact that these drugs are on the market, because the evidence for benefit is so small. And if you were in a trial and you saw these trials, you would want to be on the placebo group, because the placebo group does almost as well as the drug group, and there's no harms. But more importantly, there aren't any long-term trials to know whether the benefits outweigh the harms. And a lot of my career, I worked in hypertension, and I did have some satisfaction in treating hypertension because we did have long-term trials, 5-year, some longer trials, where we looked at the drug versus placebo, and we knew that the drugs decreased strokes and heart attacks and mortality. And so there is a setting with people with moderate to severe hypertension where taking drugs long-term has been proven to be beneficial. But none of the psychiatric drugs have been studied in that way. And if there was a trial, if it magically became available 5 years from now, or even came out now, and it showed that the drugs had the benefits outweigh the harms, then I would change my mind. But I actually believe that if those trials were done, the harms would significantly outweigh the benefits. And so just think of how much harm we could be causing in the population. And that's really what Robert Whitaker has brought to the fore, in that since we've had drugs, psychiatric drugs, there's an epidemic of mental health disability in the United States and in North America. And so if the drugs are so effective, why would that be occurring, right? So it suggests that the drugs are causing this. And that's really scary, right? But so anyway, I think that's the main thing. I don't take any drugs myself. I retired from clinical practice January of this year. And when I retired, I still had patients I was trying to help with withdrawal, 20 to 30 people, and I'm trying to find somebody to take over those cases. But one of the striking things, and maybe one of the things you'd have a hard time sort of accepting in the movie, is that people who come off, even people who come off slowly and do it just the way it's designed, still suffer for years and years afterwards. And we don't have a good explanation for that, but I had patients who were off for 6, 7 years and still having severe withdrawal effects and coming back to me just so that I could reassure them that this is something that does occur. And it has to be quite common. I mean, because I've seen all of this, and it's happening elsewhere, and there's people contacting me from all over the world who trying to get some help locally.
Thank you so much, Dr. Wright. Well, we're going to turn the floor over to the audience. Brittany, who's been doing amazing support for this event from the O'Brien Institute, is going to do a Phil Donahue. I don't know if people remember that. Questions, comments, stories?
Hi, Dr. Jim Wright. So you said something about this benzo drug working for stroke and some other ones. Could you please list them again?
Sorry, just repeat it, please.
So you mentioned that this was not working for mental health patients, but it has been found to be effective for stroke and some other things that you mentioned I just missed.
Okay, so when I was talking there, I'm talking about antihypertensive drugs. So these drugs were on the market back in the 1950s, say, and they were known to lower blood pressure. But some very smart researchers at the time said, well, we shouldn't just accept it because and put people on it long term because they lower blood pressure. We should prove that using the drugs to lower the blood pressure actually does reduce cardiovascular events. And so they did these trials, and there's about 10 trials, and we've done a systematic review in the Cochrane Library. I'm actually the coordinating editor of the Cochrane Hypertension Group. And that evidence shows that the benefits do outweigh the harms in that setting. It's not a huge benefit. I would call it a modest benefit, but it's a real benefit, and it's hard outcomes. And that's what we'd like to see in terms of if an antidepressant is so great, then why wasn't there a trial showing that the benefits outweigh the harms over the long term?
Great, thank you for that question. Any other comments? Yes?
Hi, my name is Tara, and I'm not a doctor. I'm a registered nurse, but I'm actually here more as an individual and a parent. But I'm just wondering if you could comment, like I find it very lucky that you haven't had to take any drugs or you aren't on any drugs, but my concern is that this is quite minimizing to mental illness. And so I'm just wondering, obviously it's worthy of caution, but what about people who suffer debilitating depression or debilitating anxiety? Because I think sometimes we're not medicating normal, we're medicating people who are looking for a relief of suffering of another sort. And so then I just feel very torn in that, of course, I don't want to do things to my kids that would be dangerous, but I'm not sure. We have been to many caregivers, many psychiatrists, just with a personal journey with ADHD, anxiety, depression, and I can assure you that the problems were there before I sought medication. It wasn't that we were living a jolly life and then we went and decided to get on some medication. My daughter was suffering and really suicidal prior to any medication. So it's just a comment.
Yeah, I'm certainly aware of that, and I'm certainly aware that people need some help, right? And you know, and so the drugs have been have had trials, and the trials have been up to, most of them 6 to 8 weeks, sometimes up to 12 weeks, and there is some benefit over that time. But what you should know is that there haven't been trials longer. And it doesn't mean that we should be using these drugs long term. And if there was a drug that really was highly effective long term, I would be the first person to be promoting it. But unfortunately, there isn't. And that's the reality, unfortunately.
Brooke or Lynn, would you want to follow up to the comments?
I'm not a parent.
Yeah, what? Gretchen should.
Oh, do you want to get the mic? Just so because there's people watching online.
I appreciate the comment because I think it's something really important to address, and they're very different issues. That talking about really giving informed consent to parents who are seeking treatment or adults who are seeking treatment is different from saying that your behaviors, issues, or concerns aren't real. So I think the starting point is always that it is very real for that person, and what is the most effective and safest intervention for whatever the problem is that you're dealing with. And most people have received the message that the drugs are effective and they are safe, when in fact that's not what the evidence shows. And we're seeing more and more evidence that particularly some of the issues you've talked about, for example, up to 25% of children put on stimulants will convert to developing bipolar disorder. And most parents, if they had known that up front, would not pursue the drug treatment. So I think we really need to be able to talk about both without thinking that being critical of the way we've approached psychiatric drugs, that we're insensitive to true suffering.
Thank you for that. Okay, go ahead. Now I want to be Phil Donahue.
I just wanted to comment that a couple of decades ago, when I was encountering a lot of withdrawal symptoms in people through my own research and using micronutrients to treat various kinds of mental problems, I did a search through PubMed, as we do. I'm a semi-retired academic, and that's what we do, to look for withdrawal symptoms. And I looked under withdrawal, and there were 0 articles, and I couldn't believe it. So I went to a colleague who was in the department. I was in Department of Pediatrics here before I retired. And I went to a colleague in the Department of Psychiatry, and I said, what gives? I keep bumping into this, and it's a real thing. And he said, oh, we don't call it withdrawal symptoms. We call it discontinuation syndrome.
Right.
And this is one of the greatest hoaxes that has been perpetuated in medicine, in my opinion. People knew 20 years ago about withdrawal effects. If you've ever read, there's an amazing book by a woman in Vancouver, Addiction by Prescription, her 20 years on benzodiazepines and how it destroys lives. And all that you can find is this discontinuation syndrome. I think they were afraid to call it withdrawal because there was so much fear about mental disorders at the time. And the fear was, and it was stated to me this way, that if people knew there were withdrawal symptoms, they would not take the medication. So we had to name it something else.
Thank you for that comment. Any follow-up from the panel?
Just for benzodiazepines, there's very good information in the Heather Ashton manual, and that's available on the Benzodiazepine Information Coalition site and many other sites. Actually, if you just Google it, you'll. But she's been helping people with benzodiazepine withdrawal for a long time, and it documents all of the different withdrawal symptoms that people can have, yeah.
I think because she was in the UK,
Yeah.
I think she's passed
Yeah,
away
she
Re-
now,
has,
right?
recently.
Yeah, she has.
Yeah, so was she not responsible for the guideline in the UK that said no one should be given benzos for more than, I don't remember, 4 weeks or something like
Yeah,
that?
I think so.
Right. We
Yeah.
just never had a Heather Ashton in North America.
Also, I want to, the whole word withdrawal is so interesting. David Cohen, in his interview, talked about, I'm not sure that, he said that he felt that they moved away from using the word withdrawal because they did not want these antidepressant medications to be sort of so closely associated with illicit drugs. And it was too scary a word, but I mean, it is withdrawal. But then when you step into the withdrawal community, there's great sensitivity to calling a group of people addicted to an antidepressant or addicted to a benzodiazepine, and because then they feel that the assumption is they're drug seekers, and we saw a little bit about this in the dope sick in the opioid world, that they have a problem because they're drug seekers, not because they've been addicted to an opioid. Well, so that it's really important we try to use the word physical dependency instead of addiction. But anyway, interesting.
Any other comments? We have a couple over here.
Oh, just over here?
Oh, that's right.
I guess I wanted to thank you guys first for making this an open event. We just saw it on a Facebook post and want to join and come. I was just blown away. Like, huge portions of my friends and family have been on meds or off meds, and I assumed it had been studied long term. Like, we're studying the effect of an egg for 20 years or sugar use. But this is given away to everyone, and we don't know how they last after 5 or 10 years. I guess the question is, has that been started now? Are some of the public universities following trials that are going to tell us what's going on? Sorry, thank you.
There aren't any trials that I'm aware of, unfortunately. Yeah.
No, but there has been some metadata studies that have been done, which is interesting, that they've been kind of scouring former studies and extrapolating data from those in order to make some conclusions. And, the conclusions are no more positive than the assumptions or the short-term ones. But it's nice to actually see, from my perspective, I mean, I've been paying attention to this and in it for about 5 years. I feel like I've seen a pretty serious ramp up in the way the topic is being talked about. The Guardian has a huge column that's specifically devoted to antidepressants over just prescription and antidepressant withdrawal. The UK just updated their guidelines recently on, they made a bold statement and said that talk therapy should be done first. They had to make an official statement to make that happen, but they did do it, and that's actually a huge step forward compared to where we were when I was going through this in 2016. So maybe one day.
Yeah, there is a trial called the STAR-D trial, which was the big trial that supposedly lauded the antidepressants, but it's been looked at by different researchers since it is a metadata study, which looks at a bunch of different studies, right, Jim?
I think.
And
Yeah, I don't think there was a placebo group in that. That was,
okay,
there was,
so no
yeah,
placebo, but
Yeah, so that was the flaw in that. Yeah.
Hi, I have so many things I want to say. My name's Chris. I'm a registered social worker and assistant professor in social work in Calgary at Mount Royal University, and I spent many years working in the child welfare system. And I was struck. I think there's a comparable or a story here as well that needs to be told on the child side of this. And I know it had that statement in there about the numbers of children that are medicated. But we do know that children in care are more likely to be on many medications, and that trauma is something that we, as a society, I think, tend now to go to medication for, as opposed to understanding that there are feeling awful, and working through those pieces are a part of what we have to do to get better. And so anyway, I applaud you. I think this is great work. I teach addiction and mental health and use the Saving Normal work that Alan Francis has done in my class, hoping to try and open up the minds of the younger population to critically think about things and to gather history and not just to go to the place of medication alone. So I hope that there'll be some work around that child side of things as well. So thank you so much.
And thank you for your comment. Does anybody else want to?
Hello. So I'm aware that antidepressants and anti-anxiety meds, among others, are intended for short-term emergency use, even though, of course, they're not used that way or prescribed that way often enough. But there's also a number of psychiatric disorders that are lifelong disorders, bipolar disorder, schizophrenia, among many others. How are the drugs that are prescribed for these individuals approved if they're not tested for longer than like 8 weeks, 12 weeks, when they're intended to be used for years, if not their entire life?
The fact of the matter is the FDA and Health Canada do approve these drugs with only the short-term data in terms of the randomized trials with placebo. Yeah.
So anyone in this room has far more letters after their name than I ever will, so if I say anything incorrect here, please step in. But from my understanding, there's a couple things that are happening. I'm also American, so I'm only familiar with the FDA system. But one of the things that happens is that the drug companies, when they create these drugs, they decide what studies to give to the FDA for approval. So if there was 100 drugs and 90 of them failed and said these drugs are useless or they hurt people, if they give the 10 that showed some improvement, that's what the FDA has to go on. So
It's 2, Brooke.
Two. Okay, yes. So that's what they go on. And so those 98 studies that were done, or whatever, I'm making up numbers here, but whatever was left on the cutting room floor, that's private information that we can't ever know. However, there are also studies that are, like, again, making up numbers here, but let's say 10 studies are given to the FDA for approval, and some of them show some benefit. Through the Freedom of Information Act in the US, you can actually view and read all of the studies that were presented to the FDA. And when you look at the data from that perspective, you see a very different story than the Zoloft commercial, right? So the Zoloft commercial may be pulling something out that says, patients do better on our drug. That might be one study out of however many that they're using that information, and it's why they say, it may do this, it may be caused by that. That's how they get around it. The other thing, I'm gonna stop there because the other part fell out of my head, but that's part of it.
Go to the young woman. Okay, Jim, go ahead. Dr. Dickinson.
Thank you. Thank you very much for presenting this movie. I wish we could have seen the whole long one. I think there's obviously a lot to learn. And thank you for all the presenters. As a family physician who's been around for 47 years now, it's been fascinating to see the change in the use of medications and how particularly these modern antidepressants have come in. And I must admit, hearing these stories of people on 10 different medications gives me the creeps, because I personally have never seen that, but then I'm obviously in a very particular practice that doesn't do this very much. But I do think we need to be cognizant that here we're talking particularly about the antidepressants and the anti-anxiety drugs. That yes, the old psychiatric hospital that held all of the chronic schizophrenics were emptied when the antipsychotics came in. There really is a lifelong value in some of the antipsychotic drugs, and there is a value particularly for some degree of control over bipolar, that some of the drugs for bipolar disease are long-term helpful. And we need to distinguish between them. So, yeah, I agree. I see patients who have been depressed, and Usually they've been put on antidepressants by somebody else, but sometimes I do it because there are some people who really are bad enough that it really is worthwhile giving them short-term help. But yeah, and then we try and get them off fairly quickly, and that is tough, undoubtedly. So there's a real problem, but yeah, I'm very fortunate maybe that I haven't seen some of these really long-term, trying to pull people off drugs that they've been on for long term. I can really believe that's a very serious problem. So thank you for raising awareness, and I do hope that this movie is bought by every medical school to show to their, particularly to their psychiatric trainees, but also to family practice trainees, because we need to be, as in everything else in medicine, there are benefits of what we can do, and there are harms. But the biggest hope that I would see, I'm very lucky. I work in a model, the academic model that is here, but it's also, there are other practices that work with very strongly with psychologists and so on, people who can do the talk therapies and who are not conflicted about what they're doing. The idea of a psychiatric visit 10 minutes just strikes me as being totally unethical. But sometimes people are backed into that sort of corner. We do need to spend the time with people to hear their story, to understand their story, and to really work out what the right management is. And for family physicians who are paid for a 10-minute visit, that's virtually impossible. I'm lucky, as I say, in an academic unit that's not quite as bad. But we need to be asking our politicians to provide a lot more psychology help for frontline doctors so that we can refer quickly when people are in acute distress, that they don't have to call up the helpline and say, oh, we can get you an appointment in 8 weeks. That isn't adequate. We need, when people are in acute distress, they need to be seen, and I'm sure Eddy would say, yeah, living in the waiting room, waiting all night to be seen, because the people with heart attacks come first. Yeah, people with heart attacks who are going to die, yes, they do need to come first. But it's a terrible thing to do to people, to just sit them in the waiting room in the emergency for hours on end. We need to have better systems to help people in acute distress so we can then get them out of it fairly quickly.
Yeah, I think most emergency providers would say that actually our biggest problem is not the patient in the waiting room, but it's the patient who we've already assessed and maybe started to stabilize, but definitely needs a mental health bed in the hospital, but have to spend 2 or 3 days in sometimes inhumane conditions because there are no beds upstairs for them to go to. That's where we feel the real bottleneck and real crunch and see terrible things.
Yeah, just and we need to fund talk therapy, right? I mean, a lot of it is the funding system, right? I mean, we don't fund it, and so family doctors can't do it, and psychiatrists don't get funded for talk therapy either. So,
Well, and also, perhaps someone just needs a break, and there's an interesting program in Massachusetts, Western Massachusetts, where there is a house. I think there are only about 10 beds in it, where you can go. I think there's a 5-day limit. It's not medicine. I think a doctor oversees it, but people can just take a break from what they're going through, sleep. And so I think it's a lot of pressure to put on the medical system to absorb all acute crises all the time. And maybe we need to look at other parts of society too.
And really, I mean, I was struck by the fact that most of these people in your movie have at least some financial resources.
Yes.
People who have very little financial resources, it's when they have no financial resources and simply can't stop working, can't take time away, can't split from their family, can't separate for a while or whatever, because they just have to keep going. Then it's even worse. And we have to have systems of support for those people as well.
Jim,
Jim, can you comment on this gentleman's comment on the antipsychotics? What do you know about that? I mean, from my perspective, they're studied a little bit more because it's easier to tell whether or not someone's having a schizophrenic or hallucinogenic moment than they are, depressed.
Yeah, well, I mean, we certainly have, we know of people who seem to require and do okay on antipsychotics long term, but they also can do horribly. And they can gain weight and they can become obese and get type 2 diabetes and so so the drugs are very harmful, and they have.
They've been overused, particularly in North America. As a graduate who's from Australia, we had a very different approach. And coming to North America, I really felt they were overdiagnosed and overused. When we look at the DSM, the way that North American psychiatry makes diagnoses really creeps me out. But if you go back to, say, the books of Oliver Sacks, neurologist and psychiatrist, who describes the history of the old asylums and how these drugs made a big difference to those people who recognize that, yes, they have a place, a really valuable place. Yes, they have problems too. And it's that difficult balance of benefit and harm we have to do in this, but everything we do in medicine.
Brittany, do you have some question? Or Lynn, did you want to?
I just wanted to, just for everyone to look into it, to research it. There is something called the Hearing Voices Network that is cropping up in at least across the states. It's really gaining momentum. It is people who are understanding that their voices are they're real. They talk to each other. No one is allowed into these groups. I would love to have filmed one, and I filmed a group getting ready to do one. And it just didn't make it into this film because it wasn't really medicating normal. But they are normalizing for themselves and each other the voices that are very, very real for many, many people. And it helps. I mean, it might not replace medication, but it's something for someone to try.
And some people are able to slowly withdraw and get off completely, and their life comes back to them. That's how they describe it. They describe that during the time they were on the drug, they were not completely there. And some of those people are going around and talking to people, but others have much more difficulty and are not able to get off. But it's a difficult situation for sure.
Okay, great. Thank you. We just want to hear from a couple more people. Brittany, do you have someone holding a mic there?
Hello. First of all, thank you for putting this on. And again, like the other gentleman said, for making it public, because we did the same thing, saw it on Facebook, and here we are. I had a comment to make and then also a question for you guys. My background is in health science. I did a bachelor's degree 5 or 6 years ago, and then I went back and did another bachelor's degree in dental hygiene, and I'm now in the process of specializing in orofacial myofunctional disorders. And one of the research that's coming out in that is that ADHD is linked, is maybe not necessarily a disorder on its own, but a result of sleep disorders and not getting enough oxygen to the brain during sleep, especially during developmental years. So for anybody that's interested in looking more into ADHD therapies that is not necessarily medication, that's an interesting route to go down. Not necessarily saying that is the end-all be-all, but it's very interesting. There's a few myofunctional therapists or orofacial myologists in Calgary here that are doing work with ADHD patients. And as far as my question goes, where do you make the definition of short-term versus long-term for medications? And when we talk about giving medications for emergency situations in the short term, what does that length of time look like in an ideal situation to transition someone from a state of where they need to be on this to get over the hump, so to speak, to a point of different or better, more helpful coping mechanisms?
Well, I'm going to give the question to Jim, but when the film was coming out, I showed the film to lots of people, but one was a woman who said, "Lynn, you've got to understand that my antidepressant was incredibly valuable to me for a short term." She defined it as a year. She had a traumatic event. she was absolutely unable to, she was so worked up and unable to go to a therapist that she was put on this medication. And she said that, and every person is different, but she said that that time on it got her to a place where then at about a year, she was able to then start the therapy, and she could tell that drug was not good for her. She didn't like the feel of it, but she was able to get herself to a therapist, and then she discontinued the drug. So that was her definition of short term, but Jim and Brooke might have other definitions.
It depends on the drug. I mean, benzodiazepines, as you know, can be so problematic that, but they still can be helpful. And so I prescribe benzodiazepines, but only as rescue therapy for sleep. And so if I was going to prescribe, I wouldn't give a person probably more than 5 pills. And it's really just rescue therapy to get them through that. And most people do okay with that. And once they know that this is a drug that can be, that they can become dependent on and have real problems with, and they don't want to take it on a regular basis. So benzodiazepines should never be taken long term. You become tolerant, and they no longer do anything, and then you have this big problem of getting off. So that's that situation. Acute panic attacks, again, that just treat the panic attack and get them through that, and don't keep them on long term. It's not a treatment, not an effective treatment for generalized anxiety disorder or any of these long-term conditions. For antidepressants, we don't know, but the trials are, I say, 8 to 12 weeks. So we have some evidence for that period of time. And I would say to people, try and get off as soon as possible, because there could be problems if you stay on. So not what the psychiatrists say. The psychiatrists tell people you've got to take it, and you've got to take it long term, and take it for the rest of your life many, many times. Yeah. So.
Thanks, Dr. Wright. So I just want to be respectful. Fantastic conversation. We're just respectful of the time. I want to get in 2 more comments. Brooke, did you have something?
I just want to comment on that one. I remember the other thing I was going to tell you. There are 2 books that you should read. One is Bad Science by Ben Goldacre. I wrote it down for you. That goes into how the FDA works and how things get approved, and it will answer a vast majority of your questions. The other one is Anatomy of an Epidemic by Robert Whitaker, which we've all referenced a little bit. I was reading in his book a couple days ago before I came here, and that is a big question, what is considered short term? And in his research doing metadata, so this isn't necessarily like a study that's done following people, but just he was kind of looking at time periods from about 6 months to 2 years, and somewhere in there is where people tend to drop off. And so that's purely metadata. It's not an official study of anything, but that's kind of where his timeline when he's looking at it is, and it's all in here. So I'll get back to you.
Do you want that person have? Yeah.
Hi. I'm Dr. Carol O'Neill. I'm a psychiatry registrar, so I don't know if I should be here or not. But anyway, so there's a lot to unpack from tonight, so I'll just try to remember the bits and pieces that I can. So antipsychotics, for example, I often say to students that these are exactly what they say they are. They're antipsychotics. They're not anti-schizophrenia. Psychosis is a symptom of schizophrenia. It's not schizophrenia. So it's not meant to be a standalone therapy. It's meant to be something used in conjunction with other things. There's been mention made of we used to have the asylums that then were closed down. Paradoxically, they were closed down when antipsychotics first came out because it was determined that this was a miracle drug and that there was no longer any need for them. What we lost in the process was supportive systems that actually supported these people in becoming well in other ways. Now that we don't have them, as you've mentioned about that home where people can go to, that sort of thing can be a support. However, paradoxically, in Australia, we sometimes end up with patients who are admitted quite long term. Depending what they're there for, they can become institutionalised very, very quickly. So you then see people identifying too much with their diagnosis and who then become very resistant to having their medications decreased. I tend to try and present it to my patients that it's a bit like, can I say up front how long you'll need medication for? Not necessarily. But if you break your ankle, we may put you in a plaster cast, which then comes off after a short period of time. The cast is there to support you while you do your healing. That's the purpose. For some patients, their fracture will be such that they'll have a metal plate inserted. For some of those patients, the metal plate will stay there for a short period of time, relatively speaking, and then be removed. For some patients, it will be there pretty much lifelong. So I tend to say to patients that don't necessarily consider that you've had one episode of psychosis. I certainly would not be expecting the patient to be on antipsychotics long-term or permanently. There's actually no evidence for doing that at this point. The evidence, we normally say about 12 months, but the evidence is not actually past 6 months, is my understanding. Would you agree with that? So there is a lot of work to be done in this space. I would say that a lot of this happens in the absence of being appropriately supported to do the right things with our patients. So psychiatrists often do not get an appropriate amount of time to spend with their patients, and it's often viewed that talk therapy is not what we do, and that needs to go to the psychologist. I have been told as a registrar, because I do a lot of talk therapy, which may or may not be surprising to you, but I consider this a key component of what I do, because if you go through the DSM-5, it pretty much states that medications are not the first-line therapy for almost anything. Certainly extremes of manic depression when they present acutely, extremes of depression, sometimes to allow people to engage with therapy, and obviously with psychosis. But other than that, it's pretty much other forms of therapy that should be adapted first and not just straight away going to drugs. But I've been told by my psychiatrist that's not part of your role. We need to refer on to the therapist, who unfortunately, when you said 8 weeks to get into one, I thought that's extraordinary. I'm quite impressed if you can get a patient in to a psychologist in 8 weeks, because I can't. So when we start actually having a better approach towards psychiatry, not pathologising so much mental illness, starting to direct the public away from a pill fixes everything, because that's often the psychology. I have patients who very much just want to have a medication and they're not very interested in doing therapy and get very tied to a diagnosis. When we start giving the appropriate time and the appropriate resources, we might start to move forward in this process a bit better.
Thank you very much for your comments. I really want to respect our timeline. I'm going to give you the last comment.
Try to finish it off with a bang here then. My name's Tyler. I'm here with my friend Brandon, and we've spent the last 6 months working very closely with Adele Framer of Surviving Antidepressants and Mark Horowitz, who wrote in The Lancet his hyperbolic tapering method. And what struck us as so crazy is how Mark actually learned this method from Adele and from the patient community. And the patient community basically taught themselves how to get themselves off these medications before the medical community did. And I guess as somebody who's been on antidepressants twice and told to taper off of those drugs over a 4-week period, both times by 2 different doctors, I guess my question is, what are the barriers, especially here in Canada, for adopting, Mark's method, so Mark actually co-wrote the new NHS and Royal College of Psychiatry guidelines that Brooke mentioned earlier. And so, especially here in Canada, I guess I'm like, what are the barriers to really adopting these methods? And for those who aren't familiar, going from 20 to 5 milligrams of Cipralex, for example, is quite easy. Going from 5 to 0 is like jumping off of a cliff. And so, I guess I'm trying to understand, how do we get there? Like, what's stopping us from really taking those last 5 milligrams very slowly? Just curious to hear anybody's thoughts on that.
Thanks for sharing. Any thoughts?
Anyway, I highly recommend that, and it has to be controlled by the patient, but there is supervision that needs to occur, and they need to get help along the way. And the healthcare system in Canada doesn't, the fee-for-service system doesn't allow you to spend the amount of time you need to help the person to do it. But I was in a situation where I could spend more time with patients, and so that's how I ended up doing what I did, actually.
Great way to finish. I want to offer a huge thank you. Brooke, did you want to say something?
Oh, sure, yeah. I was just going to say that, I'm 36. I started going through this when I was 15 and, kind of capped it off when I was 30. I think there's a huge, huge benefit in focusing on medical schools and people who are learning now, because they're ready to learn how to do this better. And I think that, I don't want to say that anyone else is lost and hopeless, but I do think it's going to be easier to start changing it now before we have to undo many, many years of learning. And I think that's true for the general public as well. I mean, you know, I don't know how many of you have been following the news on Cerebral in the US, but it's a complete and total disaster. And the bottom line is that regular people who are on Instagram and TikTok are getting their medical advice from Cerebral. So if you can somehow usurp that and get them the medical advice that, you know, about even just the awareness that you probably shouldn't stop taking your Cymbalta, like that's already a huge step to helping people not get into these problems, because they're reading very well health for their medical advice. That's the reality of it. So I think that from your perspective with what you guys are doing, that's really going to be valuable.
Very wise. So please join me in thanking our three panelists.